All right, I'll go ahead and share my screen now.
Thank you.
All right, can you see that okay?
Yes.
Just a second, something. Give me just 1 second. Something is not working here on my end. Okay, there we go. You see that okay as it's filling in here?
Yes.
Perfect. Well, hi, I'm Elizabeth. Thank you for the introduction and for asking me to present today. I'm very excited about sharing this information with you. As you can see from the title, we have a lot to get to today, so I will do my best to stay within the time frame here. Again, I'm a speech language pathologist. Most of my background is in skilled nursing, assisted living, long-term care, hospitals, etc. Here are the objectives for today. I won't read these word for word, but basically I'm going to explain what speech language pathologists do, how it relates to swallowing and mealtime, especially for individuals with dementia, how we assess, treat, and diagnose and come up with treatment strategies for individuals with swallowing disorders. I'm going to talk about some challenges that make mealtime difficult for individuals with dementia, and then provide some tips to hopefully enhance the mealtime experience. So what is a speech language pathologist? We work to prevent, assess, diagnose, and treat speech, language, social communication, cognitive communication, and swallowing disorders in children and adults. So really our title doesn't do us justice for all that we do, but we also do work with voice therapy as well. That's not included there, but we work in a variety of settings. And we collaborate with caregivers and professionals, mainly in the medical field, also social workers, dietitians, other therapists, etc. Before we jump into the swallowing and mealtime portion, I want to just touch quickly on definitions of dementia and some signs and symptoms. Dementia is not a specific disease. It's an overall umbrella term to describe a wide range of symptoms associated with a variety of cognitive skills. So it's not just about memory loss, as you'll see as we jump into the mealtime portion. Alzheimer's disease is the most common type, accounting for about 60 to 80% of cases. And there are many other types of dementia. Some include Lewy bodies, frontotemporal, and vascular dementia. Here are the top signs and symptoms of dementia. For time's sake, I'm not going to go into these into great detail, but you will see how these apply to the discussion around mealtime today. We make a lot of decisions around mealtime and eating. It involves sequencing, problem solving, communication, socialization, etc. So the signs and symptoms of dementia definitely affect those areas. I wanted to also discuss signs and symptoms of dementia in the IDD population and how it relates to swallowing. So basically, short-term memory loss is not usually an early sign for individuals with IDD, but we look for changes in day-to-day functions, reduced enthusiasm for daily activities, which could include mealtime, loss of interest in social interactions, and changes in personality and behavior. Something to look for would be a newer increased seizure activity, incontinence, mobility changes, and then I wanted to highlight the swallowing difficulties. So for many individuals in the IDD population, they may already have a swallowing disorder or difficulty swallowing. So signs and symptoms of dementia would be a change in that swallowing difficulty that's already present. Here are some stats on the IDD population and how it relates to swallowing disorders. It's estimated that there is an incidence of dysphagia in individuals with developmental disabilities, in about 80 to 90% of that population. They will have dysphagia during their lifetime. Dysphagia is a swallowing disorder. And most adults with an intellectual disability live in community settings, either independently or with support from families, friends, and service providers. So there's a great need for assistance during mealtime in these settings, and we'll talk about that here in a little bit as well. Here are general statistics that illustrate the prevalence of swallowing disorders for individuals with dementia. There could be many factors contributing to these high stats, including medical complications, poor caregiver support, and then just overall changes with the progression of the disease. But we estimate that there swallowing disorders occur in about 45% of those who have been diagnosed with Alzheimer's and other dementias. And this number increases as the disease severity progresses, with some degree of dysphagia found in close to 80% of individuals with dementia living in care communities. So it's a big concern for this population, and it's very multifaceted, as we'll see. So here's your Swallowing 101 course. I have a couple of slides here just to kind of explain how complex swallowing is. I want to first bring up that, and this is very important, working with individuals with dementia, eating and drinking is a voluntary process, right? Nobody else can make us eat or drink if we don't want to. So this is a huge challenge for individuals with dementia and their caregivers, as we see often individuals displaying a lack of initiation in wanting to eat or drink, or maybe they take one sip or one bite and then they're not interested in completing the meal. And it's really frustrating because we want our loved one to be healthy, to get the food they need, etc. So that's the true first phase of swallowing. But really it's the oral preparatory phase. So first, we decide we want to eat or drink something, and we put it in our mouth and we chew it, or we swish it around, kind of manipulate what we put in our mouth to prepare it to be swallowed. So in the oral phase, our tongue moves to push food towards the back of our throat once it's been prepared to trigger a swallow. In the next phase, it's called the pharyngeal phase. The swallow's triggered, and then the food that we've prepared, which we call a bolus, that's that food mixed with saliva or other liquids. The bolus moves down the upper portion of the throat, known as the pharynx. In the third phase, the esophageal phase, the food moves past the pharynx and enters the esophagus, where it moves further down into the stomach. I will show you pictures here in a minute to kind of help illustrate this. But difficulty in any one of these phases could be indicative of a swallowing disorder. Hope you can see those okay. They look a little blurry on my end, but what I want you to pay attention to is this green mass here. This is the bolus. This is the food that we've put in our mouth, that we've chewed up with saliva. You can see it's kind of already heading towards the back of the throat. The blue arrows here just show airflow, and it has a big relation to swallowing. I won't get into all of that today, but you can see that the bolus is kind of moving back. This is that first phase, the oral phase. Second phase, it's moved, this green bolus, the food is moving further towards the back of the throat. I want to point out two things here. Our soft palate, which is up here, it closes off our nasal cavity so that food and liquid don't get up into our nose, because that would be really uncomfortable. And then over here, it's a structure called the epiglottis. It flaps down to protect our airway. We don't want any food or liquids getting into our lungs. So our body just normally does this. We don't have to think about any of this. So the food kind of moves further down. And then in the third phase, it's back here into the esophagus in the esophageal phase, and it's going to our stomach where it's supposed to go. And that epiglottis opens back up so that we can breathe in and out. So that's your Swallowing 101 lesson for today. I also want to touch on cranial nerves and the swallow. I won't get too in depth here, but our cranial nerves emerge directly from the brain. Dementia is a disease of the brain. There are 5 major cranial nerves that have a huge role in swallowing function. You probably can't see the text, and that's okay, but there are very specific things that these cranial nerves control: taste, function, sensation, the movement of our tongue. For example, So if dementia is a disease of the brain, we would probably expect there to be changes to the swallow based on the nerves that are being damaged with the progression of the disease. So you may see individuals, as I said, not initiating mealtime or not wanting to eat or drink much, but they could also be experiencing decreased function of their tongue, their cheeks, their lips, their palate that I just showed you in the other picture, because dementia is impacting the communication from those nerves to those structures needed to safely swallow. So what is dysphagia? It is a swallowing disorder. So difficulty swallowing or eating is what we call a swallowing disorder or dysphagia. It can happen in any one of those phases I discussed, the oral, the pharyngeal, or the esophageal phase, diagnosed and treated by a speech language pathologist. And there are other disciplines that play a large role in diagnosing, treating, coming up with plans for management, and that's gastrointestinal physicians, ENTs, occupational therapists, dietitians, etc. Here are common causes of swallowing disorders. I won't read all of these, but as you can see, individuals may have dementia, and then they may have poor oral structures, so they may have loose-fitting dentures, and so that's kind of two things they're dealing with, and they may show signs of a swallowing disorder. So just kind of take a look here. Any change to the brain, as we saw with those cranial nerves, can point to a swallowing disorder, and then also head, neck, and mouth structural issues. Here are common signs and symptoms of a swallowing disorder. So what to be looking for if you are working with someone who has dementia, you have a family member. If you notice any of these, it could point to a swallowing disorder. So coughing during or right after eating or drinking, and that's because we're trying to protect our lungs and our airway. So our body is naturally coughing if things have gone down the wrong way. Our body's naturally trying to protect itself. Same thing with clearing your throat after eating or drinking. Every once in a while is okay, but if this is something you notice often, or maybe after every sip of liquid or after every bite, it would be a concern. A wet or a gurgly voice during or after eating or drinking, and that could point to liquid sitting on our vocal cords, which we don't want that. We don't want liquid going to our lungs. Feeling like something is stuck in your throat or your chest after eating or drinking could point to a pharyngeal or esophageal issue. So someone says, it just really feels like something's getting stuck here and I can't clear it. And, I'm not really choking, but I can feel it. So that would be a sign. Needing extra work or time to chew or swallow, having food or liquid leak from your mouth, food getting stuck in your mouth or not being able to clear food from your mouth, having a hard time breathing after meals, and then, of course, weight loss. So what's the risk of having a swallowing disorder? Swallowing disorders can contribute to something we call aspiration pneumonia. So this is a big concern for individuals with dementia because the greatest predictor of aspiration pneumonia is dependence on others for feeding, which we know a lot of individuals who have dementia depend on others for feeding. So aspiration pneumonia is when food or liquid enters the lung space. So we've all had things go down the wrong pipe or the wrong tube. We cough, we clear our throat, we get it out of there. We probably don't develop aspiration pneumonia if we're healthy enough. But in this population, if the food or liquid is not cleared, it gets into the lung space, our body kind of creates a infection around that foreign object. So aspiration pneumonia can be deadly for our elderly individuals and is a big concern. So, and it also can be silent. So someone may be aspirating and they don't show any of those signs or symptoms. They are not coughing, they're not clearing their throat, they don't have a choking episode. So big concern for individuals with dementia. Swallowing disorders can also contribute to dehydration or poor nutrition, reflux or other gastrointestinal issues, and then an overall decrease in health and an increase in other medical issues. So we think someone has a swallowing disorder. We notice some of those signs and symptoms. How do we really know, or how do we get an assessment or a diagnosis? So typically, and I'm just for an example, in a long-term care setting, observations may be made by caregivers or staff members about an individual from knowing some of those signs and symptoms of dysphagia. And they notice, oh, you know what, Mrs. Jones is coughing a lot after she eats, or she's clearing her throat, or she had a choking episode. They would then tell the speech language pathologist that is at that facility. The speech language pathologist would do an assessment called the bedside swallow exam, which is really never done in bed, ironically. So it's not safe to eat or drink in bed. So we usually have an individual sit up in a well-supported chair. We try different food items and liquids to see what they can tolerate, look for those signs and symptoms. We also address the oral motor function of the individual, make sure everything is working, there's nothing glaring that can be addressed before we go further into the diagnosis process. If we say, you know what, I am kind of noticing some things, but I don't have x-ray vision. And so this is really something in our field that has had, it's been getting a lot more recognition these days, which is great. It's called the modified barium swallow exam. So this is a fluoroscopic procedure designed to determine whether food or liquid is entering the individual's lungs, known as that aspiration I talked about. But it also permits the medical team to observe the coordination of the structures in the mouth and the throat as they're actively functioning. So you watch somebody on an x-ray eat something, and you can see exactly what is happening as it goes through those phases of swallowing. So it may be helpful in diagnosing and finding other things that are going on. Another great tool is the fiber optic endoscopic evaluation of swallowing, which we call FEES, and similar procedure, but it goes in through the nose and then assesses the structures used for swallowing to see what's going on. So big push to get these two tests done. I will say individuals with dementia are not always the best candidates for these tests because they're very, it's invasive. I mean, you have to have this big machine next to you, which can be really scary. You're sitting on the spot with someone telling you to eat or drink these things. And it can be really intimidating, and individuals have to follow simple instructions as well. So there are great tools when we can use them, but again, not always realistic for individuals with dementia. So if the individual has done one of those further instrumental exams and a swallowing disorder is identified, there are many strategies and interventions done by the SLP to help kind of get the most, let the individual have the most opportunity when they're eating and drinking. So just because if somebody's aspirating on one of those modified barium swallows, it doesn't mean they need a tube feed and that's the end of it. There are a lot of things that can be done, exercises and different ways individuals can use their muscles to chew and swallow, instruction on ways to sit or hold their head when eating, strategies to help with safe swallowing, so things that they can put into practice when they're eating and drinking, oftentimes needing caregiver support to remember those things. There are diet modifications that can be made. There are 3 levels to keep it basic. Regular diet level, which is anything that you and I eat. Mechanical soft would be any food that is softer, probably that you can squish between your 2 fingers. So a lot of raw fruits and vegetables wouldn't be allowed on that type of a diet. And then a puree diet, which is smooth food, which takes a lot of the chewing out of it if individuals are having difficulty in that area. There are also liquid consistencies that can be altered to kind of slow the rate of that bolus going down the individual's throat. So thin liquids, your basic water, all the drinks that we drink. Nectar thick is a little thicker than that, which helps slows the liquid go down. And then honey thick and pudding thick, which are as they are honey-like consistency, and then a pudding thick consistency. Other interventions include a vital stim, where they hook electrodes up to the throat area and do different exercises to kind of help get those muscles firing, and then other means of nutrition. So now we're going to jump into our mealtime considerations of dementia. So whether or not the individual has a diagnosed swallowing disorder, these are things that can become difficult for individuals who have dementia during mealtime. And then I know that I'm going to try and speed it up here because I do have a lot to get to still, and the case study portion at the end. So you may see a general disinterest in the task. The individual, sits down to eat, but they don't initiate anything. You may see an individual having trouble using cups and utensils. They may see a fork and think that it's a hairbrush, and so that they're not putting that together, that I need to use this to eat my food. Slow and reduced movements, confusion with time and place. I would be really confused if I thought it was breakfast and I was sitting down to spaghetti and meatballs and I don't have my coffee. So there could be confusion there. Visual spatial difficulties. A lot of times if there's not good contrast on a plate, if you have mashed potatoes on a white plate, on a white table, there's not a lot of contrast going on there. It might be hard for someone with dementia to distinguish what's on their plate. Difficulty communicating, of course, and this is where the caregiver usually comes into play, into helping the individual identify their preferences. And then there can be changes in taste and smell as a disease progresses. So part of what we enjoy about mealtime is the smell that comes with a lot of our favorite foods, right? Think of your coffee in the morning, a fresh batch of chocolate chip cookies. If you're not smelling what it is, it's maybe not helping you put together what's actually in front of you. There can be effects of medication that can contribute to a poor mealtime experience. Individuals may experience nausea or decreased or increased appetite. So maybe looking at medications can be helpful. Decrease in socialization. We know that eating is a very social part of our lives, and you may see individuals with dementia withdraw from typical social activities centered around eating. There can be a change in physical activity. So appetites may change due to the individual moving less or moving more. Maybe they're hungrier if they're moving more, or not as hungry if they're kind of sedentary. Changes in the muscles and nerves used for swallowing. Decreased judgment. So individuals may take too large of bites, leading to choking episodes, eating non-food items, taking a bite of something that's too hot, etc. You may notice a change in intake amount. So very, very common for individuals with dementia, not eating very much, and there's a big concern for weight loss there. And lastly, there could be an unrecognized swallowing disorder. So what can we do as the care partner to help set them up for success at mealtime? First, we need to look and see if their basic needs are being met. Do they have dentures? If they do, are they well-fitting? Are they in properly? Are they clean? Are they having oral care done before and after meals? If you're coming to lunch and you still have some of breakfast in your mouth from earlier, you're probably not ready to eat again. Hearing aids, are they able to hear you to communicate well? If they have a communication device, is it on and working to help communicate? Do they have glasses and contacts to kind of help with those visual spatial difficulties? We would want someone to be well-positioned in a supportive, comfortable chair with a table position that's adequate, not the table up here that they can't see what's on their plate, something low enough to where they can identify what's in front of them. We want individuals to maintain an upright posture. It's very unsafe to be reclined or to lean back when eating or drinking. And then if they are in a wheelchair, are they comfortable in that wheelchair? Are the wheels locked before they start to eat? And making sure they're maintaining a good posture is important. We want to check the environment. How's the background noise? Is it too quiet? Is it too loud? And this can be different for everybody, which can be difficult in some of those group settings, the group dining room, when they have maybe music on that's suitable for one individual, but not the rest. Is the lighting too bright or too dim? Where's the table located? Is it on the other side of a window and the sun is glaring in their face and they're distracted by that they're not even wanting to eat? What's on the table? Removing as much clutter as possible is really important. So it makes the individual less distracted when they're eating. And then check the room temperature. If someone's too hot or too cold, they may not be interested in eating because they're focused on the fact that they're uncomfortable. And lastly, socialization. Determine preferences for eating alone or eating with others. Eating is a very social thing, but sometimes some individuals want to enjoy their cup of coffee and their breakfast by themselves. So kind of figure out what works best for the individual with dementia. Here are some tips to set mealtime up for success. We want to consider a consistent routine. It might be beneficial for an individual with dementia to keep consistent routines around when meals are served or when they eat. So for example, if you watch a television show at 10 o'clock, it's over at 11. We know right at 11 when that show's over, we're headed down to lunch. So to cue the routine can be helpful. Try to identify food preferences. This is definitely easier said than done. And this can change day to day, hour to hour. So it's a lot of trial and error and trying to identify what an individual likes and does not like. Try and evaluate the eating times and types of meals and snacks. I'm sure all of us are different, and some of us like to have a big breakfast. Some of us don't like to eat until lunch. Some of us like a very early dinner, but sometimes we don't end up eating till 8 o'clock. So try and evaluate and assess what works best for that individual. Some people snack throughout the day and don't have 3 large meals. So be looking at what works for that individual and what does not. Explore equipment and utensil options. I will show you some examples here in a minute of what that might look like. And then the food presentation and visual considerations. Keep it simple. Too much food on one plate can be really overwhelming for individuals with dementia. So try smaller portion sizes, maybe separate bowls. I have that here, this picture on the right. So bright colored bowls, smaller portions, maybe more appealing. And maybe you would just serve one of these at a time instead of all 4 at once. The meal on the left is a typical meal you would see in a long-term care facility. There's a lot going on here. You've got a soup, a salad, spaghetti dinner, toast, vegetable. I mean, this is overwhelming for me. So I would maybe start with a drink and start with their salad and then move on to the soup and kind of say what each item is as you're presenting it to decrease the overwhelm. Here are some of those adaptive equipment and utensil options. Some of these would be recommended by a speech pathologist. Some would be recommended by an occupational therapist. So these are cups specifically for individuals with a swallowing disorder. It helps the flow of the liquid, so it's not too much at once. And then these divided plates are great, kind of helps keep things into sections. And then there's different weighted utensils and curved utensils that might be helpful for some individuals. Some general mealtime tips here for individuals with dementia. Try and set snacks up in convenient locations so that they can just kind of grab and go. Meet the individual where they're at. If they like to roam and walk the halls, grab a banana and say, here, I have this banana, would you like it? And they can take it and eat it when they want, or they'll say no thank you and you try something else later. Think of adding sweetener, seasoning, sauces, etc., as dietary restrictions allow to kind of help make food more flavorful and more appealing. Finger foods can be a great option for individuals with dementia when using utensils becomes kind of difficult. Switching up the environment may be helpful for individuals with dementia, not everybody, but maybe going outside for lunch when it's really nice out would help that individual want to eat a little bit more or just engage in that socialization of mealtime. Try a restaurant style type of meal. So pretend that you're the server, you're going to take their order, you're going to go get it, you're going to serve them, tell them that the meal's on you today when they ask for the check at the end. So kind of play into roles that might make mealtime more fun and enjoyable. And then lastly, avoid offering high calorie drinks like Ensure and Boost before a meal is given. These are great supplemental tools that I know can be very helpful for individuals with dementia, but if you're serving that first, they're sucking down that great tasting milkshake, then they might not want to eat the meal that's being served next. Very quickly here on mealtime communication, we know that communication is super important when interacting with individuals with dementia. So we want to set a positive tone. We want to make it an enjoyable experience. If the interactions before mealtime are negative, maybe there was an argument, maybe there was something that happened, that individual might not be interested in eating. Use positive facial expressions. offer patience and support, and comfort and reassurance. Tell the individual, you're doing a great job. I love that too. How does that taste? Provide a lot of positive communication around eating. Try not to criticize, correct, or argue with the individual. If they say that they love their peanut butter and jelly sandwich, but it's a tuna fish sandwich, there's really no point in correcting them. Let them enjoy that sandwich. Tell them that you had the same thing and it tasted great. Try and use short and simple instructions, yes and no questions, positive language again, decrease the distractions. And sometimes it's helpful to use outside cues and signs. So maybe you show them 2 pictures of what's being served that day, or write things down to help with the communication. Some tips to encourage dignified dining. So as individuals with dementia progress in the disease and they may need more help with eating and drinking, we have a role and responsibility to make sure that it's a dignified experience. We want to listen to the individual. If they say, I do not want that for lunch, don't argue, just say, okay, offer something else. Using a clothing protector may make some individuals feel like a child if it looks like a bib, but on the other hand, getting food all over your clothes and walking around the rest of the day like that can also be embarrassing. So talk to the family and the individual on what their preferences are, facilitate a natural and familiar eating environment, allow them time to enjoy the meal. Do not rush them. It is not going to end well for anybody. Empower them to make choices and tell them what they're eating, especially if an individual is on a modified diet. That mechanical soft and the puree texture, sometimes it does not look like what it is. So you have to tell them, this is your spaghetti, this is your fruit, and they have a right to know what they're eating. Frequently check the food and liquid temperatures, make sure things aren't too hot or too cold. Eliminate the distractions and be attentive to the individual who's eating. Allow them to do what they can, but offer support when needed. If they're having trouble picking up their fork, help them with a hand over hand, help them cut up their food. Do not force feed individuals with dementia. It goes back to my first step in the eating process. We are not ready to eat unless we decide we are ready to eat. Assist with cleanup as needed, wiping hands down and faces and cleaning up clothes that may have gotten stained. Common causes of choking. I'm not going to read all these because we're running out of time here, but essentially individuals with dementia rely on others more and more for eating. So we have a role to, a lot of these, the responsibility is placed on the individual serving the meal. So paying attention to if they're eating the right diet texture, if they're being too distracted while they're eating, etc. And then these are general safe swallowing strategies for individuals with dementia who do or do not have a swallowing disorder. Maintain that upright position when eating or drinking. Try to take small bites. Alternate small bites with small sips of liquid to wash things down. Alternate temperatures and taste to increase sensations. Eat slowly. Avoid talking while chewing. Check for pocketed foods, so food that would be stored in the cheeks or under the tongue. And sit in an upright position for at least 30 to 45 minutes after a meal if the individual can tolerate that. Here are my resources and my references, and I will stop sharing now and turn it over to you, Margie. Oh, you're muted.
Muted. Were there any, I don't see any questions in the chat. Does anyone have any questions? Elizabeth, that was really, personally, I haven't known a lot about the work that a speech pathologist does. So thank you.
Yeah, no problem.